tēnā tātou, nisa kulatanaka, kia rana, talofa lava, malole, and good morning. Welcome to this session. I'm Ben Darlow. I am a musculoskeletal physiotherapy specialist, and I have interests in pain, musculoskeletal pain and physical activity, and I will deliver you sessions across this module in all three of those. But this morning it's going to be about mamai, and a few years ago I was going through and adding more kupa Māori into this presentation, and my daughter looked over my shoulder and said, "But Dad, you haven't got a karakia in there." It's like, "Oh, normally I do it in class, but feel free to add one." So this is Lucy with her karakia.
Te Māori nui, te Māori roa, te Māori whakaia, ki te whaiao, ki te ao marama, si hei Māori ora.
Thank you, Lucy. So a karakia, I'd just like to start to bring us all together and focus on the learning. What we're going to be learning about this morning is about pain. Now, within the curriculum map, which hopefully you do look at from time to time, from the start of last year, there was a completely new pain curriculum because we went through and rebuilt it based upon feedback from students and others. And the sorts of learning outcomes that we're going to touch on today are some of the science and theories for understanding pain, but also more about the complex and multidimensional, individual specific nature of pain and how you might go around assessing pain in people and things to think about when you are managing people in pain. And so this is the sort of the pedagogical model that we are working with, that all focused on the needs of the person in pain, which will be different across conditions, across contexts and across populations. Right, so to start, I'm going to just ask you to pull out your phones and we will change to the VVox app. A couple of questions that I'd just like to contextualise this. Okay, you can still join as we're going, but you can start answering if you've already joined. The question is, have you been to see a doctor because something hurt? Does anyone not have a device? I have a spare one if needed. Cool. Just waiting for the last couple. I'll probably come through on the next slide. Right, and so that is almost all of you have been to see a doctor because something hurt, and it's the most common reason to go and consult a health professional. So I've got a follow-on question from that, and that's whether the doctor or doctors that you have seen explained what pain actually is and how it's made within the body or within your person. Wow. That's telling, hey? Well, it's interesting anyway. Why do you think that is?
I didn't feel like it was necessary.
Right. Not the focus at that point in time? Mm-hmm.
They assumed that the problem was just that you had pain and they're more focused on getting rid of that pain than explaining why.
Right, so they might be able to get rid of it without explaining anything more about it. Yes, other reasons?
Because it's kind of complex, so it's like,
Yeah.
why bother?
Yes. There's one other common reason that GPs have said to me.
Time.
Time is often, that goes with all sorts of explanations. Another one that they think is more pain specific is that they're worried that it might cause people to focus more on the pain. So certainly the key thing that comes out, I've interviewed a lot of GPs about this, and they're like, look, it's really complex. I don't understand it very well myself, so I'm not very well positioned to explain it. And the other thing they say is, look, people already understand pain, so I don't need to waste time on that or spend time on that. But if you think that, what is it, about 30% of our population live with long-term pain. If we thought about other long-term conditions, say if your long-term condition was shortness of breath, do you think that sort of information, what it is, how it's made, what it's influenced, would be helpful for the person?
Yeah, why? Just so they have a better understanding of their condition and sort of how to, what to do to make it better and what to avoid to make it worse.
Yeah, so their ability to self-care is much greater if they are empowered through some information, and then they can make choices that might be the right ones for them. And I would argue that we're not providing that opportunity to many people with pain, and that can leave them with some real challenges. So we're just going to explain a little bit more, explore a little bit more around pain. Now, don't kill the VBOX because we will come back to it, but we won't come back to it for another 10 minutes or so. No, we've done that. Okay, so this one we're just going to do a show of hands rather than anything more technical. What I want you to do is to choose the symbol that you think best represents the relationship between mamai and whara, okay, between acute pain and tissue injury. So the top one is equals, the second one is not at all related to, the third one is loosely associated, fourth one is closely associated, fifth one is bigger than, less than, or proportional to. So I just want you guys to put up your hands. Okay, so, and there's no sitting on the fence on this. So if you think equals is the best representation, if you can raise your hand. Okay, if you think not at all related, go on, you can be brave. Loosely associated. Put them right up because we've got physical activity this afternoon. We must get started now. Okay, so that's probably, it's over a third, maybe almost, not quite a half. Okay, closely associated. That's most of the rest. Greater than, less than, proportional to. We've got one of that. So what's really interesting about that is already there is, diversity in the understanding within this group. And so it means that assessment that people already know what pain is, so I don't need to explain it, might not necessarily hold true, particularly when the one that most patients will walk into your office with is this one, is that their pain is a direct representation of what has gone wrong in their body. And nobody in this rōpū selected that. So it means already your understanding as a health professional is quite different from that of the general population. And if we're going to have meaningful interactions with people, we've got to resolve that difference, or else you're going to be talking past each other. Now, I want to do a quick exercise. This shouldn't take long. I'll give you 3 minutes. I'm going to take a piece of paper each, and I want you to put numbers 1 to 4 on it. Can you split those up and then pass them along? Don't worry what's on the other side of the paper. It is purely scrap from the photocopier for recycling. I want you to write down at least one example of when you might have pain without injury, at least one example of when you might have a lot of pain for a small injury, one of when you might have a small amount of pain with a large injury, and one of when you might have injury without experiencing any pain at all. Okay? Now this is part of your terms requirement for your module, so you must have at least 4, or else there will be remediation. We will discuss these afterwards as well, so you don't need to do any discussion whilst you're writing. And you shouldn't need to use your devices because Google is not your solution to this. You should already know them because it's the beauty of pain is you have all got a wonderful, rich, diverse experience of pain already. Okay, so put down your pens. Pick up your piece of paper. Pick up your piece of paper. Have a quick read of it. But we're now going to engage, I'm an academic, I like peer review, and I quite like random peer review, no blind peer review. So screw it up into a ball. And disseminate those with your peers in a very random manner, so just keep them going. No, passing around. We don't want anyone to be whakama about sharing their ideas as to what these examples might be. Okay, there's one on the floor down there. Has anyone not got one? Anyone else not got one? Anyone got two? Anyone not throw one? If you had a really good idea and it doesn't come up, then you feel free to share your own idea rather than the one on your paper. Okay, so let's go through with those and see what ideas people come up with. Who's got something good written on their page for pain without injury?
Someone, I don't know whose this was.
You shouldn't.
Yeah, they put pinch. Someone pinches you.
Right.
Yeah.
So does everyone agree that if they get pinched, it hurts? Do people agree you can be pinched without being injured? So why does that hurt? There's no wrong answers. Yeah.
Because your body perceives there's a risk of injury, so it wants you to react before you get injured, therefore you feel the pain.
Yeah, so that ability to react before tissue injury is really adaptive, hey? And so the stimulation of the tissues is enough to initiate that process without requiring any tissue damage to occur. Yeah, excellent. Well, who else has got a good example of pain without injury?
Headache.
Headache, yeah. What do they hurt?
Sorry?
Why do they hurt?
Could be a number of reasons.
Yeah.
Sometimes dehydration.
Right. So there might be alters in fluid balance, might be alterations in inflammatory chemicals or other things in the brain. It's a whole range of things that might happen, but they're not associated with tissue damage, always. Because obviously headache could be associated with tissue damage. Okay? So again, there is stimulation of nociceptors that isn't associated with actually tissue disruption having occurred, but that causes the system to think there might be an issue it needs to protect. Okay? And I always find headache really interesting because most people, when they wake up with a headache, do not assume that they've suffered a head injury, particularly if their head has not been hit recently. Whereas most people who wake up with backache assume that they have had a back injury. And physiologically are probably very similar processes. Awesome, okay. Anyone else have a good one for, I'm sure there's one other good example that usually comes through.
I've got grief written down here.
Right, yes, exactly. So, pain is there to protect us from a threat, hey? The loss of a loved one is very threatening. So we can have pain that is not actually embodied in a physical disruption or a physical sensation. But people generally differentiate that pain that's embodied as opposed to pain that is more emotional or spiritual. Did anyone have phantom limb pain written on their pager?
Amputated limb.
I beg your pardon?
Like an amputated limb.
Yes. Yeah, although the amputated limb cannot hurt.
Yeah. But
Because, why can't an amputated limb hurt?
does it not have the limb anymore?
It's not connected to your brain.
It's not connected to a brain. No brain, no pain. Okay? But what does happen to people who have had an amputated limb?
They don't have the limb.
That's an excellent observation. What's a common experience?
But they still feel like they experience that they have a limb because they've had a limb their entire life, and now that they don't have it, they're like, they still feel like it's there because their brain is so used to having something there.
Yeah, because the brain, how do you feel your limb? What goes on in your brain? Which parts of it are stimulated so you can localize sensations from there?
Feel like the nervous system.
Yes.
But
Anyone got ideas of how do we locate things in our bodies?
Postcentral gyring.
I beg your pardon?
Is it the postcentral gyring?
Well, it's particularly the sensory homunculus.
Yeah.
And so if you look at your homunculus, it's got a representation of your entire body.
Yeah.
When you lose the limb, they do not remove the part of your homunculus that represents that limb, which therefore means you've got all of the neural architecture you need to make that limb hurt or create other sensations, because people get other phantom limb sensations as well. And often I've seen people clinically where it's horrible is when commonly motorcyclists, who the last thing they were doing before they lost their arm was slamming on their brakes as hard as they could. and they get this horrible phantom limb pain of their fingernails digging in to the palm of their hand. But it's really hard to treat that when you're not wearing that hand anymore. So one thing that has actually been shown to be quite helpful for them is to use a mirror and look at a reflection of the other hand, because the brain interprets that as seeing the thing that's in the space it expects that hand to inhabit as relaxing, and that can provide relief. And often people who live with that sort of experience travel with their mirror box. And the first thing they do when they arrive in a new location is relax it off. Awesome. Okay, so that is pain without injury. A lot of pain for a small injury. You can read it off your papers, so you don't need to come up with any ideas yourself right now, and there should be an example in front of everyone. Yeah. What's written on your paper?
Oh, sorry, what was the question?
So what's an example of a lot of pain for a small injury?
Cut.
Cut.
Yeah.
Yeah, particularly what type of cut? A paper cut. Why do paper cuts hurt so much?
Doesn't hurt as much as the just like annoying.
Yeah, so one, there's a real annoyance, frustration factor that something as silly as a piece of paper just cuts you. Who's usually doing something they enjoy at the time that they are interacting with that piece of paper? There's often not much better to do than there is to hurt. But in addition to that, I mean, it's interesting to me that often when you chop yourself, when you're slicing onions, and you go quite a lot deeper than the paper cut, it does not hurt as much as the paper cut does. When you must be going through all of the same sensory receptors. It might be that the paper is actually microscopically rougher and so you get a bit of a wider cut, but it might be the range of the other factors that you're talking about. It's just how annoying it is that will influence that. Okay, what about a small amount of pain for a large injury?
Burn.
Yes, so particularly a 3rd degree burn?
Yeah.
Why?
You just moved all the receptors.
Yeah, you've cauterized all of the superficial layers of your dermis where most of those nociceptors live. And so the brain doesn't get the nociceptive information to say this is as bad as it is. Now that's what happens initially. People who have had serious burns actually then have globalized hypersensitivity through the rest of their bodies for the rest of their lives, which is a long-term consequence of that. But certainly if you're not activating those peripheral nociceptors, then you might not get as much pain. Yeah, other types of large injuries or small amounts of pain that you're going to have to watch out for in emergency departments and the like.
Fractures?
So fractures, it might be. Often fractures do have a reasonable amount of pain with them, although sometimes something like a compression fracture might not. Stress fractures might not, so those more gradual process type ones as well. And some of those can be quite dangerous, particularly if you're thinking about on your in your hip. Yeah, what else?
Does losing your arm or like leg ever hurt?
I don't have any lived experience of that, but I would guess it depends how it happens and what sort of degree of threat to life and limb. To limb there's obviously about what degree of threat to your life there is, and so we'll talk about that in injury without pain. But visceral injuries are ones that you will need to look out for, because why don't visceral injuries often hurt that much?
Different type of receptors.
Yeah, you've got nowhere near the sensory innervation of them that you do of your periphery. Brain injuries would be another one that you'd need to look at the same way. Okay, what about an injury without pain at all? Read it off your paper, don't look at me. Is that, so peripheral neuropathy? Yeah, so again, if your sensory network is deficient, then your brain won't get the information about the growing ulcer in order to, or the excessive pressure in order to tell you to respond to that, which is why foot care can be so dangerous for people with something like diabetes. Yeah? Others? There must be something written on your paper unless you all ran out of steam by 4.
This person with hypertension, pretty similar to what peripheral neuropathy is like vasculopathy. You can't really tell before.
Yeah, and potentially those very gradual onset things, because the nervous system adapts, it never passes that threshold where it gets to that level where it needs to protect. And the other ones where you commonly see this is on battlefields or sports fields, where there was the Olympic semi-final for the 400 metre relay in London, and the third runner for the Americans, I think he was, as he was going around the top bend, you can see his fibular fracture as he goes out into Verus. He ran the next 250 metres, passed the baton, and then could not wait there any longer. Now, he didn't run as fast as he should have. He did it like a 46 second rather than a 44 second 400 metres. But he still ran faster than probably 99.9% of humanity has ever moved. But the moment he handed on the baton, he couldn't walk very well. What's happening between those 2 points? What happens when you pass on the baton?
With the mind just taking over and kind of like your body just blocking out the pain because you know you have to get to a certain goal. So if you get to a certain goal, kind of overcome the pain that you're in.
It's not blocking out the pain, it's not making the pain. So the best quote for that I heard came from an American neuroscientist who said, "You will not hurt if you have something more important to do." Because pain is there to ensure our survival. And so there'd be no point in we're running away from the saber-toothed tiger and we stand on something sharp and stop running and get eaten. And so the system has adapted a prioritization system. And if there's something more important, then we won't hurt. But how much more important you need to be depends on how bad that injury is. And that's why in battlefields, I mean, there are videos from the Falklands of people running across battlefields carrying their mates but without wearing a foot. In that situation, doesn't matter what's going on in the body, you're going to die if you stop. Whereas in a different situation of someone who's sitting down at work, it might take a relatively small amount of tissue stimulation or perceived need to protect to elevate it above the priority of what's going on the computer. And so there's this constant balance. So what that exercise shows us is that I was disingenuous when I asked you to choose that relationship. Because it could be any one of those relationships, and which one it is will change, not only dependent upon the person and dependent upon the mamai, the whara rather, but also dependent upon the context. And it's that which makes pain so interesting, but also makes it so important to be able to give people an understanding that allows them to make sense of that in their lives, because otherwise it's unpredictable, it's confusing, and it can be very life-limiting. So this is a model of pain that we developed for a training program where we're doing the GPs about back pain, which is a lot of it's based upon what we've learnt from functional MRI scanning of things that influence the parts of the brain that make pain. But most pain experiences start with information that comes from te tinana, okay? So some form of tissue stimulation or wharanga or the potential for wharanga, inflammation or sensitization, a change in the sensitivity of those nociceptors. But although most pain experiences start with nociception, nociception is neither necessary nor is it sufficient on its own to result in a pain experience. And it's often not a linear relationship. Now, when you're reading about this, you will often see information talking about pain receptors and pain signals. They are misnomers. There is no such thing as a pain receptor. There are high threshold sensors that pick up stimulation at higher levels of intensity that may well be indicative of something dangerous going on. There are pathways that feed into your nociceptive system. But until that information arrives in your brain, it cannot be pain, because the only computer you have that is powerful enough to create any of your sensory perceptions is your brain. So when I'm explaining that to patients, often I find, although this is going to age me, a USB mouse is quite a good example of how a nociceptor works. So the first thing is if that nociceptor is not plugged into the computer, then you will not, you can click it all you like and nothing's going to happen. If it is switched into the computer needs to be switched on. That's why your Glasgow coma scale works. Computer's not on, brain don't make pain, body doesn't respond. But if all of that's working, the sense the computer makes of the click is entirely dependent upon the context, but also its response will be dependent upon what that interpretation. And so often, no error occurred is what your brain is saying. So there's a lot of nociceptive information travelling up your spinal cords all the time that you're not aware of. Right now, there are pressure sensors under your bottoms that are saying, hey, danger, a lot of pressure in the bum. And your brain's saying, nah, I've sat down for longer than this in chairs that are less comfortable than this. Haven't had ischemic bottom disease yet, so I think you're okay, you don't need to know about this. Although, when someone draws your attention or focus to it, you might decide those chairs aren't quite as comfortable as they could be. It might be frustrating. Windows has detected that you have moved your mouse. Please restart your computer. People who have things like recurrent back pain, it can be really frustrating when they have another episode because it really can influence and impact their life and what they can do. But at the same point, they often know what they've done in the past. They know that it will get better. And so it's not the end of the world. For some people, it's a good thing. It's an indicator that actually their overload training at the gym was successful because they have delayed onset muscle soreness, which suggests to them that they might get some hypertrophy. Some people go seeking it. People who like to get branded or pierced. That endorphin release that comes with a strong pain experience can be part of the draw. But if the system interprets it as this, catastrophic failure, how it responds will be very different to if it interprets no error occurred. So we've got to look at what's the information that the system is using to come to that conclusion if we're going to help people with pain. Any questions about that as a model? Cool. Okay, so means that, oh yeah, I will just draw your attention to, this makes it look like it's all just the nervous system, but actually your immune system has an incredible influence on modulating and changing pain, so important to be aware of. Okay, now, next thing that will be quite different to how you will understand pain to how your patients understand pain is that pain is an output from the brain. It's not an input. But also, probably your understanding of vision, hearing, taste will be different from your patient groups, and that they are also outputs of the brain. And so vision can be a really good into trying to explain some of these principles to people. So most people think that their vision is like a direct projection onto the back of their head somewhere. Of all the light goes in, forms this picture, and that's what I see. But what the data tell us is that only about 10% of the information that you use to construct vision comes through your karu. Why is that?
I guess it's like memory. You just formed your own picture in your head.
So you're using memory to assist with that process? Yes?
It's like the peripherals of our vision actually not that clear to us, and so our brain fills in the gaps.
So our brain fills in the gaps. Why is it doing this?
Looks a lot nicer.
It looks a lot nicer. If you can imagine something beautiful out there when maybe it's just another lecture theatre. What else are the benefits of doing that? Yeah? I'm sure you had an idea then. Yes. Sorry, I don't know your names, and I probably won't see you quite enough to be able to learn them. Any idea? Going across?
It's like easier if you have less information input for your brain to do other things.
Yeah, so easier for your brain to do other things, but also just easier to process it. It's much more efficient this way. So if we processed 100% of that information, we would need to have brains that were much bigger or much slower. Neither of those options are particularly attractive for survival. Because either the lion's already eaten you by the time you worked out that he's jumping at you, or you've worked it out, but by the time you've carried your head away, he's going to catch you anyway. Okay, so visual illusions can therefore be quite interesting ways of showing this to patients. Which piece of train track's longest? So are they both the same length or are they different? Put up your hands if you think they're the same. Does anyone think they're different? Who thinks they look different in that image? What's going on? Magic. Well, our brains aren't magic. Any idea, back row?
Does it to do with the distance from the camera? Like the camera's angled a specific way and it's like distance?
That's a good idea, but in order for that to be that perspective effect, you'd need it to be a long way away. I would posit. What I've been told is your brain does funny things with curves. And so when it's adjusting things for curves, and because it's got the, I mean, it is a little bit tricky because the top curve of a radius of a circle is obviously a bit longer than the bottom one. But your brain just automatically thinks, oh yeah, top piece small, bottom piece large. Okay, next one. Oh yes, just are they parallel? Would anyone like to stand up and look at them from the side? If you get on you get up and move. See what happens as you move from looking at them front to coming round to the side. You see?
Are we comparing the black one?
Either, but for me, it's the blue ones that look wonky when I look at them from the front. So again, there's contextual information in there that's making your brain think that they are not parallel. Okay, for the next one, we're going to go for a line straight down here. So those on that side, okay, we can go straight down there if you'd rather. Those on that side, I want you to just read the word on the right-hand side of the screen. This side, you just read the word on the left-hand side of the screen. Okay, swap sides you're looking at. Okay, what did you observe when you did that?
Your brain should switch between words and make it sound right.
So the word you sounded was consistent with the one you were looking at. And it switched, the same sound sounded different depending on which word you were reading, hey? How does that happen? So the way we organise sensory information is hierarchical. Vision is the top of our hierarchy. It's the same reason that if you get a Sauvignon Blanc and you put a couple of drops of red food colouring in it and you give it to a master of wine, and they will smell the cherry notes and the chocolate and everything else you might expect out of the Pinot. Because that sensory information through their eyes overpowers everything that they would normally rely on in their nose. Same reason when you cut yourself when you're slicing those onions, first thing you do is this, because you want to see how deep is that? Am I bleeding much? Is it very flappy? Do I need to get a stitch? And you can get that information really accurately with your eyes. But you cannot do that if the problem is inside your back. And so that then leaves people with having to try and rely on other sources of data, and they can be much less accurate for looking at. Okay, final one of these, and we're going to go back to the Vivox app for it, but what it's going to ask you to do is decide, tile A, which one of these four is it best match the colour of, and tile B, which one of these does it best match the colour of. You should be able to jump back in if your phone has disconnected from that in between times. So this is tile A that it's asking you for first. Hopefully it's bigger on your phone than it is up the screen, so you can still make a fair judgment. Okay. So the vast majority of you thought it was number 1. Most of the rest of you thought number 2. Some thought it was number 3. Let's go for the next one. So this is tile B. Which colour does it best represent? Which is pretty much the reverse. Interesting, I'd be interested if it was the same person who said 3 last time who had said 2 in the second, but we will have a look at what the other evidence would tell us. Hopefully, yes. Now this I made myself with my own editing skills, and so I can assure you there's nothing groovy that's gone on here other than white block out. One more time. Okay, so they are both the same colour. Is there anyone who does not believe me when I say that?
That's a joke.
You sure? It's usually one in every class. And I do have a hard copy you can chop out and check. Okay. So, if we agree that they are not the same colour, why do they look... I mean, if we agree they are the same colour, but they look different, why is that so? Why do they look different? Yeah?
Our brain processes it differently in the context of a shadow.
Right, so your brain can see that there's a light source coming from the top right. It can see there's an object blocking that, so it knows that everything in the shadow will look darker than it really is. Yeah? What else? Over here? Yeah?
Kind of like looking at it relative to the squares around me. So you think that it's a bit lighter, the colours around it dark.
Yes, and so there's the contrast between that square and the ones around it. And put up your hand if you've seen a checkerboard before. Come on, put your hands up. Okay, so that's a pattern that everyone is quite aware of. And so it means your brain knows that that one and that one and that one and that one are the same colour. So there's a whole lot of contextual information there that means that it assumes that this colour is the same as that one and it's quite different to this one. But it's not. Now, the reason why I think this is really relevant to pain is now you guys know that. Who can see those two as being the same colour? Can you?
Yeah, if you like zoom your eyes out and go like slightly cross-eyed, I reckon you can. Like if you stare at it for ages, you're upside down. I was just doing it and I didn't actually get it.
Right. So yeah, if you do funky things with the information your brain has access to, it can get a different interpretation. Now, I think this is really relevant for people with persistent pain. I've looked at this, I don't know, I reckon at least 200 times. When I look at it, they still look different. People with persistent pain are often told you're not injured anymore or your injury's healed or there's no reason for you to hurt anymore. But they keep on hurting and they often get blamed for that. No, I told you there's not a problem there. Why are you still making this up? That's a decision that your brain is making entirely without you, and you can't just tell it to do something different. If I wanted to look at those two as the same, I would need to go through a learning process repetitively over time to teach my brain they are the same. Now, there's no benefit for me in doing that, so I'm not willing to put the time and effort into it. But I could imagine how that would have to be. I would do things like, with the piece of paper, I'd chop out the two squares and I'd move them to see each other, I'd swap them around. So I would do things like that. I'd probably block out some of the context. Maybe I'd paint the other squares a different colour. There's a whole range of different ways that I can give my brain different experiences and data that would help it to make a different interpretation. But I couldn't do that by just being told or by being blamed for what my brain is doing.
Sorry, but surely like these optical illusions, like they're a thing because you're looking at it at a certain angle. Like if I was to look at a checkerboard,
Yes.
like just just anything random, I don't like. You typically wouldn't be in this situation, or like if I was reading like something and I really wanted the person to say what I was wanting them to say, but I was reading, it doesn't just make it out of my brain. Or something like because on that video, it seemed to work, but
Yes.
that unfortunately in the real world it doesn't happen like that.
So in terms of your brain making interpretations based upon pre-existing pattern recognition and pre-existing knowledge and those sorts of things?
Well, I guess you're talking about how like your brain values like what you read, and it meant that you could hear.
Okay. Oh, so the interaction between the hierarchy of sensory information. Yeah.
Like, how come in the real, if I wanted someone to say that I got this grade or something, then I read that thing. It doesn't. I don't hear.
Oh,
it.
I mean, yes, we're manipulating to make it. I mean, that sound information is ambiguous. That was done there, and so if it was a clear piece of information where actually the person said brainstorm, and just like I'm saying it, and you read green needle, you still would hear brainstorm when I'm saying that information is ambiguous, and the brain is using the best information it has available to try and resolve that ambiguity. And so I think that's where the relevance to pain is, but also in terms of the hierarchy of that information. If you show someone a scan of their back with a big disruption of their disc, that image will have a powerful effect on how their brain interprets and manages sensory information from their back. And so there is still that hierarchy, and there might be other information coming from their back that actually it's quite safe to bend. But if their image is every time I bend, I'm aggravating this big injury that's going on inside my back, and I've got a risk of doing damage to my nerves and my spinal cord, well, that is going to usurp other sensory information or auditory information from me saying, no, you're fine to bend. Does that answer? Cool. Okay, so what I think is a good enough explanation of what pain is that pain is an unpleasant. If it was pleasant, it wouldn't be any use to us. Conscious. If we're unconscious, we don't make it. Experience produced by the roro, not by the foot, when the interpretation of all of the available information indicates that part of the tinana needs to be whakamaru. Does that make sense? So key to that is it's about protection. So it's a protective response to a perceived threat, which is why the pinch can hurt even though there's no damage, or the headache. So it's an alarm system, and like any alarm system, if it only rang after the dangerous event had already happened, it would be of no use to us. Okay, so it's there to protect us from whara. It's not there to describe it. It's the alarm, not the insurance report or insurance claim. And that differentiation is really important to help people make sense of their ongoing pain experience. And it means that actually understanding those different sources of information that the roro is using to come to the conclusion that you need to be protected is vital. And actually, you often can't change what's going on inside someone's knee or someone's back within your consultation. But in terms of their understanding of the horapaki, well, you can have a large influence on that. What's the situation? What are their beliefs around that? What are their previous experiences or their expectation? What are their whakaaro? Are they thinking that this is a horrific thing that's going to have a really bad impact on their life, or that they're going to have surgery or something like that? Are they very vigilant? Were they already vigilant about protecting that part of their body? And how are they feeling? If someone is already takarere, then they're already under threat. So a new threat is going to be much more threatening, and the system's going to respond differently. So we want to explore these things, and there's good data that actually those sorts of constructs predict people's recovery from a pain experience much better than what is going on within their body, particularly for back pain, but actually for shoulder pain, there's good research around this as well. So things like people who have low self-efficacy beliefs. So if their confidence to do things despite being sore is low, their likelihood of recovery is also lower. If someone has low recovery expectations, they are less likely to recover, independent of what type of injury they have. People who have higher levels of fear avoidance beliefs. Does anyone know what a fear avoidance belief is? Back row, I haven't heard from you yet. Kia ora. Do you know what a fear avoidance belief is? Any ideas? Going to the left? Oh, you her left, my left. Anyone? You can almost guess, but fear avoidance belief is when you avoid a activity or movement for fear that you will injure yourself or for fear that you will make your pain worse. And again, that is predictive of outcomes from back pain. Same for those who catastrophize or who expect their management to be more passive. So the thing that I want you to take out of that, though, is that those variables that are more likely to predict outcomes than physical factors don't just affect how someone copes or behaves or responds. They affect the pain experience itself. And that is going to have the influence on how they behave. But it means that you can influence their pain experience by giving them more information or different information that might influence those things. And what we know with people with back pain is that they often have an attentional focus towards information that confirms or reinforces their understanding that this is bad. They already have a prejudice towards their back. In the same way that people who have depression may have a self-prejudice towards themselves and are paying attention to information that confirms their belief that they have low value, that nobody loves them, when discounting all of the experiences they have in their life that suggest that they have lots of people who value them, who love them, who seek their company. So that means that in order to help people who have pain, we want to find out what are the things that are influencing that perceived threat. And so, does anyone know what a yellow flag is? Hopefully you'll see them once you're out in clinic, but they are a psychosocial variable or factor that predicts worse outcomes. And so they're attitudes, they're beliefs, they are compensation factors, they are family relationships, they are expectations, they are healthcare information. Now, problem with that is there's a whole heap within there. And when I talk to GPs and say, do you use those? They say, look, there's so much in that I don't have enough time. So what we've done in our research is break those down into some smaller groups. And one is the beliefs which increase the threat associated with pain, but that you might be able to influence within your consultation room. Whereas the other are factors which we know will change the pain experience, but actually you won't be able to influence today. You can't change the fact that they can't pay the mortgage. You can't change the fact that they have a very negative, unsafe relationship with their boss. But you can acknowledge that and help them to understand that this will feel differently to how it would do if they weren't in those situations right now. But for the beliefs, these, as long as you elicit them, that you can get some really illuminating stuff. So this was a guy who he had recurrent episodes of back pain across his life. And I asked him, he was just in another acute episode, and he had been picking up, just a little potted violet or something. And I said, what was going through your mind the moment you first felt that pain? And he said, the only thing that was going through my mind was the seriousness of the disalignment of my back. You get scared in the sense that you could damage your spinal cord or anything to such an extent that you might become paralysed. Now that's a catastrophic belief, hey? Would you expect that lifting a potted flower could result in someone having paralysis? However, when you work back through his story, it's very understandable how he ended up in that position. So when his back hurt, he went to see his chiropractor. Now, I could do one of these stories for any health discipline you like, but this particular one was chiropractor, so I'm not necessarily saying negative things about chiropractors. But the chiropractor manipulated his back and told him he was putting it back into alignment. So his understanding was that when his back hurt, it was out of alignment. His experience was that with each of these repeated episodes, he had more pain than he had in the previous one. So it would make sense that he was further out of alignment. Now you guys have done anatomy, hey? If you get your two vertebrae a long way out of alignment, what will happen to your spinal cord? You'll damage it, yeah? If you damage your spinal cord, what could happen? Paralysis. So that makes perfect sense. But you know that you need a truck to result in that level of disruption, not a pot plant. You know, you're trying to disarticulate a spine, you need a myotome and a big hammer. So you could have a conversation with him around that. Because you imagine if that's what's going through your head, you're not going to want to move much, hey? And you're not going to want to do anything with pot plants again. And that's going to limit that person's life much more than is likely necessary. But only if you identify it and only if you have the conversation. Now, we already talked about those. What I want you guys to do now is to break up into groups of maybe 5. And I want you to come up with 5 questions. We're going to do this in, well, 5 minutes should be enough. 5 questions that you can use to explore what is threatening about a pain experience with someone. Okay, so think about the way you would word those. I also want you to, once you've got your 5, to prioritise them, because we'll go around each group, and if one group's already said yours, then you can immediately take the second most important one off your list. Does it make sense? Questions? Good? Okay, you've got 5 minutes, so we'll be done by 12:05. Or done this section, done. Okay, cool. So we will start down here. What's number 1 on your list? Behind you.
What do you think is going on, or what do you think it means?
Yeah, excellent. So, nice open question. What do you think's going on in your knee, your back, your whatever? What do you think it means when you feel that pain? And that's really interesting to start to get that information from people. And you'll hear quite different things from different people. Excellent. Okay, you now?
We said what concerns you most about this pain.
Yeah, excellent. Because we want to know what concerns people, so we should ask them. And often, initially when we train doctors to do this process with people with back pain, and they said, start asking them about those sorts of things, they're going to think I don't believe them, they're going to think I think it's all in their head. But they say, oh no, actually, it was just a really patient-centered way of getting information from them. And people never knew I cared about what was concerning them, so they'd never told me in the past. So asking that explicitly is really good. And it's quite nice to go start with what concerns you most, because you can get the top of the list, but that then opens the, other things that concern you, which means that sometimes the things that are lower on the list actually are the things that are more deeply embedded in that concern schema. Okay, this group?
How is it affecting your life?
Yeah, so what's the impact that this is having? Because that can be really important for if it means that I can't look after my kids, or I can't go to work and therefore I'm in an insecure work environment, I might lose my job. Well, that threat is going to be much higher, and so therefore it's likely the system will be protecting the person more. But also for your ability as a doctor to be able to help this person navigate it, you being able to advocate and support them with those things, however that might be, can be really helpful. Awesome. Cool. Back.
We had, what does the pain stop you doing? Or what scares you the most about your pain? What's the worst you think could happen?
Yeah, so, different wording for similar thing in term, but often you ask the question the first time, you get a blank look, and so having a different wording for, what's it stopping you doing? But also things, what are you avoiding because of this? Or what are you worried might make this worse? Because then you really get into some of those more fear avoidance type beliefs. But also I like how you then went into what's the worst that it could be. Often when you say, oh, what do you think's going on? Oh, I guess I've just sprained it. What's the worst you think it could be? Well, I am really worried that it could be my prostate cancer coming back. And so being able to dig down to some of those things which might not be the top of mind, but that actually are worth addressing is really helpful. Okay, so coming back to this group.
So piggybacking off what makes you worry about the pain, it's what makes you say that. So if they say, oh, I'm worried it might be cancer or something, what makes you worry about cancer?
Yes. Or also you can say, can you tell me more about that? Sometimes what questions are a little bit threatening in terms of just, oh, what makes you think that? You know, obviously your phrasing will influence that, but people can interpret it as being a challenge to what they just said. So often can you tell me more about that? Welcomes more information, but doesn't put any value judgment. Did you have something else you were about to share then as well?
Yeah, and have you had this pain in the past?
Yeah, so exploring those past pain experiences and what they have learnt from that are really important, but also particularly, if they've had a really serious pain experience or really serious problem with this in the past, we know that there's going to be nervous system sensitivity and a whole lot of learned responses that will likely mean this winds up much more quickly than it would have done had they not had that in the past. And so that can be really helpful to let people help people navigate. Excellent. So let's see. So these are the questions that we used in our study with the GPs. That where we took these from is when we did a whole lot of interviews with people with back pain, and we looked at, well, what were the questions we asked that seemed to bring out a lot of that information about threat. And I mean, a lot of these things you've already got. So what do you think you've done? You know, that, as you'd said, what's the worst that could be happening? Or different ways of wording that. How bad is it? How severe is it? You know, what do you fear most about it? So I think we had that over in the back corner. When you feel the pain, what's it telling you? What does it mean? I think we had that down the back here. Do you think you could make it worse? And is there anything that worries you or concerns you about at the moment, which I've subsequently updated to what worries you most? So well done on the way you phrase that, because I find that works better. Because there's still almost a question in there like, well, is there anything that worries you? Like maybe you wouldn't be worried, whereas it's unusual not to be worried when you're going to seek health care about a pain experience, because the reason why you go is because there's uncertainty that you need to resolve. About half the people who experience back pain never go and see a health professional about it because they have enough certainty from the data sources they already have that they don't think they need more information. Any questions about asking those sorts of questions of people with with any pain?
So it's just because we've learned in class like all the Socrates stuff. Right?
Yes.
And is this like how we approach? How do we know like when to approach like in this way? I guess with like which pain? Well, that's the right words. When do we use like think about like as a mind-body thing?
I would always think of it as a complex phenomena with a whole range of influences and a whole range of data points that I could capture from the person. And I would always think that this information is probably, for me, that tells me much more about what I might do to help the person than when I get an intensity rating off them or some of those other things. Well, I mean, I'd say this aligns quite well with your ICE type moniker. It's their ideas, their concerns, their expectations. What we encouraged the GPs to do was to do this first. So you ask your opening question, whatever that is, and then hopefully you shut up and bite your tongue for as long as possible while the person talks. But then for where you delve into is this stuff before you get into those much more closed questions that you might be using with Socrates type approach. Because what the GP said to us, if they ask that in that initial part, well, the conversation's very open, then it doesn't feel like, again, I'm challenging people. It's just, we're just trying to get a good picture of where this is at. And then I go into my more specific questions to probe those things that might be particular bits of information which the person hasn't thought to share but are helpful for you to conceptualise their problem or work out what to do. Whereas often prior, the first thing the GPs had gone to after that opening gambit was doing the red flags. But what their experience of doing that was, it raised their anxiety, but it also raised the anxiety of their patient. Oh, here you are, I just came in with a sore back and you're asking me whether I've broken it or whether I've got cancer. What? I might not be able to pee. That's bad. So it's quite good to put those things, which are very unlikely in the general scheme of things compared to these things to influence their outcome, putting them later on. And what the GPs told us afterwards, and what they found is finding out this information early made their consultations much more efficient. Because if you find out in the last minute of your consultation the person's worried about ending up in a wheelchair, you can't do much with that information. But if you find out right at the start, you can make sure you're gathering the information from them that helps you to make a determination as to whether that's likely. You might not normally do a neurological examination with someone who has local back pain. But if they are worried about paralysis or they're worried they've got a pinched nerve, well, it's a really good time to do a neurological examination because otherwise you can't give them an answer on whether or not that's likely in their circumstance. And so, I would encourage you to try doing this early. But, you guys, you'll all go on placement soon and you'll observe how the GPs you work with are managing pain because you will certainly see people in pain. What I would encourage you to do is if there's an opportunity, say, can I take part of the history or can I talk to the person afterwards or do whatever you can so that you get a chance for exploring these sorts of things. Because always when someone encourages you to do something different to what you're usually doing in a consult, it feels clumsy and difficult to start with. But actually, once you start practicing it and give it a go, you'll see, actually, patients like telling you about these things. And it gives you a much, much richer picture of what's going on. And so, encourage you to try and put it into play. And if you are doing the history before the doctor comes in and does other things, try and do this early and see how that feels.
So, regardless of the pain, we should be doing.
Yeah, look, if you've got someone who has just come into A&E after they've had a major motor vehicle accident, that's not going to be your go-to at that point in time. But in a primary care context where the person is ambulatory, I would always want those to be part of that conversation. And ankle sprains I have had come in not weight-bearing, but the information I've found out by asking those questions has enabled me to give them other information to think about, which has enabled them to walk out fully weight-bearing. Because it just changes completely how the system is making sense of it. And so it's an opportunity that you don't want to miss. And it's really cool when it happens. Because that's the other thing GPs say. When you've effectively reassured someone and you can see a change in them, it's a really good afternoon. And so it's a fun part of practice. So that's why it's so important to find out what this means to the person. It's also important to use a consistent explanatory model. So that's the risk of not providing any pain information when the person comes in an acute pain episode and they're left thinking that, what I'm feeling is a direct representation of the sprain in my muscle or the tear in my ligament. Because then when 6 months later they come back and they're still in the same amount of pain, still feels the same to them, but suddenly they get told that, probably your work stress or your way in which you're ruminating about this or your anger management issues are all influencing this, they've suddenly been blamed for something that feels exactly the same as when it started. Whereas if you've got a model from the start that encompasses all the different influences on pain, but potentially has more focus at this point in time in the information that might be coming from your tissues, if that's relevant, still enables you to shift focus over time, but it's not a sudden blame of, I thought it was something I could help you with, but now it's something that's your fault, which is often where people are left. It's important to think about your own beliefs about pain and injury. We've done work that shows that healthcare professionals who have higher levels of fear avoidance beliefs, their patients have higher levels of fear avoidance beliefs. For health professionals that have very biomedical beliefs, so they align things much more with structural disruption, their patients are much more biomedically focused in the way they think about managing their problem. So you want to think about your own beliefs and how you are communicating those to your patients. We want to do anything we can to decrease the threat. Because if you can make this less threatening, if that's appropriate, you want to explore the data to make sure that's appropriate, but that will be helpful. And we want to help people to get moving. Because we're going to talk about physical activity this afternoon, but that's the healthiest thing a human can do. So in order to do that, I'm going to give you one model which I find really helpful for explaining that to people, and then that will be the end of the session, and then we can go and have lunch before physical activity. But this also might be something that you get the opportunity to share whilst you're in practice. Now, I would use a whiteboard normally, but that one is way too small. Okay, so we can look at this on the screen. So all tissues in your body have an amount of load or force they could take before you break them. Yeah? So if you imagine the volar plate under my finger there, if I bend that back far enough, I can snap it. Now, what I'd like you all to do, yeah, exactly, grab hold of your finger. Make sure you get your thumb under it so you've got a good fulcrum and you've got a good couple of fingers on there. Okay, bend it backwards. Keep going. A little bit further. A little bit further. Sorry, what was it you said?
Oh, I was going to swear because
it hurt. It hurt. Okay, let it go.
Yep.
Okay, whose finger hurt when they did that? Most of them? Who's injured their finger? Most not. And that's the beauty of pain, as we talked about. That pain comes on before tissue disruption, and it's that protective buffer that helps our survival. However, it doesn't mean you can't get that finger caught in someone's jersey at rugby, or you die for a catch at cricket and you get it caught in the ground and it suddenly bends back faster or stronger than you can control. And when that happens, you'll be injured. Now, if you injure tissues, their ability to accommodate force will be less whilst we wait for them to heal, and how much less will depend on the degree of tissue disruption. But what your nervous system will do is that buffer that you have after that will be much wider. There's a whole range of reasons why that will happen. There's likely going to be an inflammatory response, and so you're going to get secondary sensitization of the nociceptors and mechanoreceptors in the area of that inflammation. But there's also going to be all of the brain trying to make sense of it, and it wants to do nothing to disrupt that healing tissue. And so that's why it wants to be much more protective. So if say I've got an element here and I move my hand towards the element, hotter, 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 hurts, but I pull it away, I don't get burnt, I fall on it, I burn myself. The system wants me to protect that hand and not go around and disrupt that healing tissue and not get it all infected and everything else. And so that's why I'm going to have a much wider buffer at that point in time. So that system's very good. But if I hang out below that pain threshold all the time, one, I will be very protected. There's no risk of me disrupting those tissues further. But there are also a whole lot of things that add value to my life that would be above that pain threshold, so they'd be sore, but are actually below the tissue tolerance. And so they're actually completely safe. And so it would cause me to limit my life more than might be necessary. In addition to that, we get better and better at making pain over time because our nervous systems learn. And so actually how much we can do can progressively diminish. And often people think, oh, I'll just wait until it heals and then I'll be okay. But that's not necessarily the data that your brain has access to make the decision as to whether or not you still need to be protected. So you could ignore the pain altogether and say, well, Ben told me it was all in my head. Which I hope isn't quite what I've said, but it is all in your brain. So you ignore it altogether. Problem with that is at some point in there, the nervous system's going to say, hey, I told you to look after yourself. I told you louder. I yelled at you. And now I'm having to scream at you. So I am going to scream at you very loudly, and I'm going to scream at you even after that load goes. So it dumps a whole lot of CGRP and other neurotransmitter into your dorsal horn, which means your brain continues to be bombarded with danger signals well after the danger has passed. That's unpleasant. And most people whom you come across who have had chronic persistent pain experiences will really know this whole flare pattern, the boom-bust type approach. But it will feel to them like they have injured themselves further every time that happens. It's quite hard to self-harm. I mean, there are obviously members of our community who do, but on the whole, it's much more a neurophysiological process that will be going on with that. But it's not very efficient, and it can cause the nervous system to be sensitised further. So it's probably not what you want to aim for. So what I would encourage people to do, what I would say, is that it's invariably safe to do stuff that hurts a bit. But there's no point in doing so much that you flare it up. So you start conservatively, and then you progressively build up over time. And what that does is that gives the nervous system information that actually I don't need to protect as much as I thought I did, because you just did something I didn't think was safe and nothing went wrong, and so therefore next time we can probably do that. And by continuing to gather data over time, the system gets more and more reassured. And if you need it, most of the time the healing of the tissue is going to happen on its own, but that progressive process will certainly not be bad for stimulating tissue remodeling. What questions do you have about that as a model?
How do you know, like, whether your limits or like into the theorem, like, can't go to that level?
So yeah, trial and error is the only way you could really find that out. But my encouragement to people is to initially start at the lower end of of how much the pain they are pushing into, but then to see what happens over time. So there are people whom actually, they've got an incredibly sensitised nervous system, and actually relatively little pain could cause a flare, but they're the minority. There are people whom actually they can make their eyes water with their ischial pain as they're sitting, but the moment they stand off the chair, it doesn't hurt anymore. And so for them, actually, they can, have quite a high intensity of pain they're pushing up with. But that's a learning over time by progressively sitting with the pain for longer and longer and longer. Other questions? Yes?
What place does analgesia have? Covering?
Yeah, because patients worry that they'll take 2 Panadol and all of a sudden their pain tolerance will be up here, hey? Does anyone know what the evidence suggests Panadol does to the pain threshold?
Does it lower it?
No, it doesn't lower it, so it might raise it in some people, but the difference is no greater than placebo for most musculoskeletal pain. And if it does, it's minuscule. So it might have a little bit of an instance here. There's no way that I give you 2 Panadol and you can bend your finger back far enough to rupture that ligament, hey? If we add a couple of Voltaren on there, can you bend your finger back far enough to break it? No? We add some codeine, tramadol, ketamine, meth. Yeah, meth you're getting into what you need to do in order to be able to injure yourself without your nervous system protecting you. So medication should not be first line care for most pain experiences because the evidence says it doesn't work. There's just been a large trial that a colleague has done in Sydney of oxycodone for acute back pain versus placebo. Guess which performed better? Placebo outperformed oxycodone. Okay, so we are overusing most of those things because we assumed they work, and the evidence tells us that most of them don't work. Anti-inflammatories, if you're looking for a healing response, they are not helpful. So generally speaking, not giving medication and giving the person a chance to recover without is helpful, but if you do give medication, give people confidence that they are just nudging that a little bit more, and if that helps them do more of what's valuable in their lives and the side effects are manageable and the risk is low, well, that's a conversation you can have with the person, but there is no risk they will harm themselves as a result. Yeah?
So if someone wants to have an open fracture,
yeah,
can they get away with just no pain?
So I would say for a open fracture, that the difference between the pain threshold and the tissue tolerance is so low that we can't safely teach someone where to load that, and so we need internal fixation and non-weight bearing for a period. However, there are a lot of things like a fibular fracture where we previously thought that it wasn't safe to load, which now most people will be loading in a moon boot, because actually you can load in that zone, and the load is really helpful as well for stimulating that bone remodeling and avoiding the consequences of non-weight bearing. Place where you need to adjust a little bit is if someone has a tendinosis. Often those tendon overload injuries, it's the next day when they get their flare rather than directly afterwards. Same if they've got a very sensitized dorsal horn. So it just means you've got to push out your window between when the activity is and when you make the assessment of whether that was too much or not. But other than that, the model still works. Okay, so I would encourage you to explain that to your mother and your flatmate and others, because the doctors who have been using that have found that's a really good way of empowering, giving the person the tools to make decisions about how active they should be, but also giving them self-efficacy. We know that the stronger the self-efficacy, the stronger the recovery will be. I will put a link on that on the Moodle page, and so you can go through there. But I would, with a patient, I would draw it with them, because then we're co-constructing the information and it's so much more personalised rather than seeing it off a presentation. Right, so hopefully we have addressed some of those things around ways of understanding pain, how it's so context specific and individual specific, and ways that you might assess the experience of someone in pain to enhance what you're already doing with your Socrates or your other assessment. I thank you for your attention. I enjoyed that. And I look forward to talking to you about physical activity after lunch. I strongly encourage you to do some over lunch, because it is a beautiful day in Pōneke, but also it gets your brains working as well as your body's working, and it is healthy. So I look forward to seeing you after your exercise. Ka kite anō.